Okay, and this is the final result that we had for this patient. I think combining both physiology and imaging for a young patient here will probably give him the best possible outcomes in today's data, in today's practice, in today's knowledge. We hope that this stent will last for a long time, and we did whatever we can to give him the best possible. All right, so now we move on to a second case, which I think is more interesting. This is a 54-year-old gentleman, again, young. In Malaysia, we do tend to get younger patients. Our MI mean age is 45 to 50. Yeah, so we tend to get younger patients with multivessel diseases. Smoker came for assessment after being treated for a non-STEMI. So he was treated with a low molecular heparin for 5 days and was discharged and referred to us. So he has underlying diabetes and hypertension. I will show you his angiogram of the RCA. So at one glance, we may not be very, taken aback by this gram. You might think that there's a mild plaque or so on. But when you look closely, especially at the RAO view, there is a suspicious lesion at the mid RCA. Yeah, all right. So we did take that into account, and we want to know what is going on there. And then when we look at the LAD, there is also a lesion at the proximal LAD. So now when you come to a non-STEMI case, this is often the issue, yeah? We do not know which is actually the culprit artery per se. Is it the RCA or is it the LAD? And sometimes the ECG is also not helpful. So we did a FFR study for the LAD, and I would say that this FFR is clearly in the negative side, yeah, 0.85. Although the lesions to me at one glance, I would say without a physiology study, I will go ahead and label it as a severe lesion, more than 70% stenosis, and I'll go ahead with an angioplasty. But here, the FFR is 0.85. So what do you do? What about the RCA? The RCA here, again, the RFR is 0.95. And we did an FFR study, again, 0.95. So this patient has a non-STEMI, and both lesions were FFR negative. So what are we going to do? Are we going to stop here? Based on today's recommendation, yes, that is the recommendation to stop. But are you sure this is the best practice? But for this patient, we were randomized to the OCT and FFR group. Therefore, we did a OCT study for the LAD. Now, look closely to this OCT study. We can see clearly a ruptured plaque. Yeah, this is a ruptured plaque. It clearly tells us that this is, in fact, the culprit artery that caused him to have the non-STEMI. And this plaque is unstable, and there is significant stenosis there. Of course, you may argue that optimal medical therapy may be enough, but we do know that some patients, even with negative FFR, tend to still have events. Now, when you do the RCA, it's even more interesting. Looking at that, look, there is a dissection seen at the area of interest. So again, which is the culprit artery? Is it the RCA or is it the LAD? For me personally, I would feel that the LAD is the culprit artery because of ruptured plaque. But here again, in this vessel, we do see a dissection. So again, both vessels, this kind of OCT findings, when you do more OCT, you do tend to see more things. But what do you do with the information is, I think, more important. So what do you do with this information? So based on this clinical trial, we will have to go ahead and do a angioplasty for this patient. And we did indeed proceed with angioplasty for the LAD, implanting a stent. And the stent, of course, is optimized, no dissection, well expanded and well opposed. And the RCA also, we did a angioplasty and we seal off the so-called dissection. Now, this was the final results for the patient. And of course, to begin with, the FFR is already negative. Subsequently, after we repeat, is of course also negative. So will this bring benefit to the patient? I personally believe very much so, especially the ruptured plaque, where they have significant plaque burden. Leaving it alone, I think it's not a good idea. But of course, the full paper will be out later this year, and we'll await the final results. So just to summarize what I've talked about, coronary angiography is good. It's been our best friend. But again, IVUS has been consistently shown to be better than coronary angiography alone. And again, multiple studies have shown that OCT does bring down MACE events and even cardiac death. So again, why not? Why do we still do not practice a routine IVUS OCT for all our patients? So again, just to end our discussion here, optimizing multi-vessel PCI remains, I would say, a work in progress. Combining both physiology and imaging may give patients better long-term outcomes. I think more studies are needed to assess this prognostication of patients with vulnerable plaque anatomy, because we know we are at the edge here. We know that some patients with negative FFR still come back with event. Is this patient coming back with event have vulnerable plaque that is detectable from the first angiography that we did if we do a OCT study? I think in a couple of years back, 2 years ago, the TCT has already came out with this editorial. Intravascular imaging should be a routine practice to inform PCI based on the recommendation of ACC Interventional Council. I think this is really the way we are headed. Imaging will become more and more commonplace, and indeed will become more of a routine for us in the cath lab. With that, I thank you very much for having me. Thank you very much.